So these are the body cavities we have. Dorsal body cavity, which is the cranial cavity, and the spinal cord, vertebral body cavity, and the ventral body cavities, which are thoracic cavity, abdominal cavity, and pelvic cavity. So dorsal body cavity, color with gold yellow, and ventral body cavities, they are colored with red, and the separation is, let's say, vertebral body. So these vertebral body, anterior to the vertebral body is ventral body cavity, and posterior to the vertebral body is dorsal body cavity. And we were talking about this thoracic cavity. Thoracic cavity separated from the abdominal cavity by the diaphragm. If you look at the diaphragm, it is a dome-shaped structure. On the sagittal view, this is the sagittal view, lateral view, or sagittal view, it is dome-shaped. On the anterior-posterior or coronal view, it is also again dome-shaped. Yeah. So when the diaphragm is relaxed, it is in a dome shape. When the diaphragm contracts, it just flattens out. So that is the cavity we were talking about. And the boundaries of the thoracic cavities, of course, you have seen the diagram already. So inferior boundary would be the diaphragms, which separate the diaphragm, which separate thoracic cavity from the abdominal cavity. What is the upper boundary? Upper boundary is first rib, and at the back, thoracic 1 vertebra, at the front, the sternum and the associated costal cartilages. And on either side, right side and left side, we have ribs, which are carved, coming from the back, carved, and then come attached to the sternum via the chondral cartilage. And we talk about the sternum. Sternum is made of 3 main portions. Number 1, manubrium sternum. Number 2, body of the sternum, and number 3, cartilage portions, which is called xiphi sternum or xiphoid process. And the junction between the manubrium sternum and the body of the sternum is a little bit bent like that. If you look from the side, this bent area is called angle, the angle of sternum or sternum angle, which is also called Lewis, angle of Lewis. So these are the boundary, posterior boundary, thoracic 1 to thoracic 12 vertebra. On the lateral side, either side, we have ribs. Anteriorly, we get sternum and the costal cartilages. And if we remember ourselves, the first 2 7th rib, they have their own costal cartilage to come and attach to the sternum. But beyond the 7th rib, so 8, 9, 10, they have to come and join to this costal cartilage of the 7th rib. And 10 and 11, they don't even attach to the costal cartilage, they are just floating ribs. So, and this is the right side of the thoracic cavity, this is the left side of the thoracic cavity, and the partition with the abdominal cavity is diaphragm, and in between 2 lungs we have the space which is called mediastinum. Mediastinum is the space in between 2 lungs, right lungs and the left lung. Look at the respiratory tract. We have our nose, the aperture into the nose, the air goes in, 2, 1 on the right, 1 on the left. That is what we call nostril. And this inside the nose, we will say nasal cavity. Nasal cavity, we have to go into the nasopharynx, oropharynx, and laryngopharynx. And the air we breathe in, we have to go through nasal, oro, and laryngopharynx. And finally, we have to go into the larynx. And larynx is what we call throat. And throat, and then from the larynx, it will lead into the trachea. Trachea we divide into right and left main bronchus or primary bronchus, the same, yeah? The main bronchus, in other words, primary bronchus, the main bronchus for the right lung, the main bronchus for the left lung, and they go into the lungs. And finally, divide and divide and divide. And this area, where the bronchus goes into the lung, it is called hilum, H-I-L-U-M. Hilum is the space where the major blood vessels and the bronchus goes into the lungs. We have right lungs, we have left lungs, and the difference between right lung and left lung is we have 3 lobes in the right lung. On the left side, we have only 2 lobes, the upper lobe and lower lobe. On the right lungs, we got upper lobe, middle lobe, and the lower lobe. And the fissure, the division of these lobes, these are fissures. This is going transverse, so transverse fissure, and this is going oblique, so oblique fissure, and this is going oblique, so it is called oblique fissure. And look at our respiratory tract at the nasal cavity. We said, you know, these are the bony ridges coming from the wall of the nose and curve and curvy, which increase the surface area. And these bone ridges, they are covered with the nasal epithelium. Nasal epithelium, the way we try to remember is we have a lot of nasal secretions. If you cry, nasal secretion come out. If you have infection in the nose, nasal secretion come out. If you inhale dusty air, a lot of nasal secretion come out. So the epithelium, the lining surface of the nasal cavity is lined with the pseudostratified, columnar, ciliated epithelium. The name is big, but if you divide a pseudo-stratified, it is not really stratified, it is pseudo, it is fake, it looks like multiple layer, but actually it is only one layer, pseudo-stratified. Columnar is the tall epithelium. So tall cells, as we say, they don't need to be multiple layer. So there are not many stratified columnar epithelium. There are many stratified, pseudo-stratified columnar epithelium, and pseudo-stratified columnar ciliated because these surfaces have little hairs to entrap the dust and all the pollens we breathe in. So this sort of epithelium will line the nose. Of course, this is the air filter chamber, isn't it? So the air we breathe in, we come through the nose straight into the nose. And this is a very important place to filter the air we breathe in so that nothing dusty will go into our lungs. So for that, this nasal epithelium is covered with the pseudostratified, ciliated columnar epithelium. So this cilia will entrap all the dust we breathe in. And this columnar epithelium, they are long and tall, and therefore they have a lot of glands, like mucus glands and serous glands. So serous gland will secrete serous nasal secretion, mucus gland will secrete thick mucus secretion. And that is the way we filter our air in our nasal cavity. And this, behind the nasal cavity, we have the nasopharynx. So the air from the nasal cavity will enters into the nasopharynx through the aperture opening, which is called posterior nasal aperture. That is not a science word, isn't it? It's at the back, posterior, from the nose, nasal aperture. Aperture means opening. And don't forget, in the nasal cavity, we have the nasopharyngeal tonsil. Hey, pharyngeal tonsil is here. It is one and only sitting in the center at the back of our nasal cavity. And don't forget this little opening, pharyngotympanic membrane, that tube. So pharyngo means from the pharynx, it is located in the pharynx. Tympanic means it is in the middle ear. So this little tube, if you follow, it will lead into the middle ear cavity. What does it do? It adjusts the air pressure inside our middle ear. Yeah. So like if you do swallow it, the air from the pharynx will go into the ear. So when you fly, you can do that to adjust the pressure in the middle ear. So this is the air we breathe in now gets into the nasopharynx, and it has to go into the oropharynx. So oropharynx is the place of the pharynx posterior to the oral cavity, the mouth. Yeah. So the mouth, we are not going to say the mouth. We will say oral cavity, nasal cavity, and oral cavity. So the portion of the pharynx at the back, posterior to the oral cavity, we will call oropharynx. So the partition between the nasal cavity and oral cavity is at the front, it is bony, which is called the hard palate, bony palate, and this bony palate will extend with the soft tissue, and that is called the soft palate. So the palate separate the nasal cavity and oral cavity. And if we think about that, this bony palate or hard palate continue as the soft palate, and that little soft tissue structure will hang down from the top. That is like a little grapes hanging down from the ceiling. That is what we call uvula. Uvula, it is the definition of uvula is little grapes. So little grapes hanging down from the top of the soft palate. So this uvula is going to flip upwards to block the channel between the oropharynx and nasopharynx. So when you swallow some food, this uvula will flip up, block the channel, so the food you swallow will not get into the nose. Of course, sometimes if you choke, this uvula cannot close properly, and the food will come out from the nose. Okay, and then now we got to from the nasopharynx, we are going into the oropharynx, and from oropharynx, just before it goes into the trachea, that portion of the pharynx is called laryngopharynx. Laryngopharynx. So nasopharynx, also oropharynx, and laryngopharynx is going to lead to the larynx. Larynx is our throat. Yeah. So look at the relationship between the larynx, laryngopharynx, and the esophagus. So esophagus, our swallowing tube. If we swallow some food, the food will go from the oral cavity into the oropharynx, and then laryngopharynx, and then it will go into the esophagus. Esophagus is posterior to the trachea or larynx. So there need to be some crossing. The air we breathe in come along from the back and has to go forward. Yeah. So, and the food we eat will go backward into the esophagus. So how does it happen? So look at this little big structure here. That is what we call epiglottis. Epiglottis is the structure, soft tissue cartilaginous structure, which is sitting at the base of the tongue here. So look at that, this little flap of soft tissue cartilaginous structure. And when we swallow, which is called deglutition, D-E-G-L-U-T-A-T-I-O-N, that is the terminology for swallowing. When we swallow, our epiglottis will flip downwards. And at the same time, this larynx will be pulled upwards. So the function is when we swallow, the epiglottis will come down and the larynx will go up. So that is the way we close our airway. So the epiglottis will come down, larynx will go up. So normally it is like that when we are breathing in, but when we swallow, the epiglottis come down, larynx go up. So that's the way we block our airway, and the food we swallow will go directly into the esophagus. It is very complex structure. So that's why, this action, our swallowing, this epiglottis coming down, the larynx going up, and esophagus must relax. So all these are all complex. Therefore, if someone who has stroke, who has stroke, and like if they cannot swallow for like 2-3 months, they lost their ability to swallow. They can lose their ability to swallow. And therefore, speech and language therapy, we have to train these people when they awake how to swallow. Because this is an action we do every day. We take everything for granted. But this is a very complex arrangement. So when we swallow, the epiglottis will come down, the larynx muscle will pull the larynx up, and then this function will close the airway, and the food will go into the esophagus. Okay, let's move on. So this is what I was talking about. So these are the inside the nasal cavity. So these are the nasal concaves. These are the bony ridges, which is covered with the epithelium, pseudostratified columnar epithelium. These nasal concaves, we have 3. Like at the top, we have superior, in the middle concave, and it is inferior. So superior, middle, and inferior nasal concaves. And underneath the nasal concave, this area, the space underneath the nasal concave is called nasal meatus. So why do we do that? It increases the surface area. If we look from, that was the sagittal section. If we look coronal section, so looking at from really front, right eye, left eye, this is the nasal cavity. Look at that, guys. Look at these nasal concaves. They are coming from the side wall of the nasal cavity, bony ridges, and they are coming into the nose and the cavity and cali, middle nasal concave, cavity and cali, upper nasal concave, cavity and cali. So what do they do? Yeah, they are just like the sharp edge, isn't it? So this area, the bony surface is lined with the pseudostratified columnar ciliated epithelium. Pseudostratified, not really stratified, but it looks like a multiple layers. Columnar, long, big, tall cells, ciliated, it has cells, so that it entraps all the debris we breathe in, and it has a mucus gland, serous gland, it will just spit it out, everything. So look at these, nasal concave. These are the bony ridges coming from the side wall of the nasal cavity, and cuff and cali to increase the surface area so that we can filter the air as much as we can within a confined, limited space. And don't forget, in between the right side of the nose, left side of the nose, nasal cavity is separated by the internasal septum. Look at that, that is amazing. This is the oral cavity. This must be the heart palate, which we can see, yeah? So this is just a reminder, pseudostratified columnar ciliated epithelium. And we said it lines the respiratory tract. Of course, it's respiratory tract. This diagram is showing only the trachea, but actually, it's just like from the nasal cavity down to the bronchioles. Bronchioles are small little airways, which are the near terminal ends of the respiratory tract. So the whole, nearly the whole, the respiratory tract is lined by this type of epithelium. It is a lovely structure. So just try to show you the nasopharynx, oropharynx, and laryngopharynx. Laryngopharynx will lead to larynx, and the larynx will become trachea. So hey, open your mouth. Let's have a look. So open your mouth. This is our tongue. And if we look ourselves in the mirror, and if we say ah, and look inside the mirror, and this is the little uvula, which is like a little grapes hanging down from the ceiling, which flip upwards to to separate the nasal cavity and oral cavity, so that the food we swallow cannot go into the nasal cavity. Brilliant, brilliant thinking. And this is our lung. We got right lung and left lung. Right lung has 3 lobes, left lung has 2 lobes, and left lung has this cardiac notch. So in the exam, if I give you a lung specimen, and if I ask you which lung it is it right lung or is it left lung? I believe you have you will be able to answer the question. Professor, this is right lung. Why? Because there are 3 lobes in this, and I cannot see the cardiac notch. Professor, this is the left lung. Why is that? Because I can see the cardiac notch, and it only has 2 lobes. So that's the way we differentiate between right lungs and the left lung in the cadaver. And of course, both lungs, they are sitting on the dome, diaphragm, right diaphragm, left diaphragm. These are the dome-shaped structures, fibromuscular structures. So look at that lungs again. Look at the lungs again. So hey, look at that right side of the lung, left side of right side of the lung, left side of the lung. You can see the cardiac notch. On the left side, we only have 2 upper lobe and middle lobe separated by the oblique, going obliquely. So oblique fissure, and in the right side, we have oblique fissure, and we also have horizontal fissure. Therefore, we will have 3 lobes, right lobe, middle lobe, and so let's say this superior lobe or middle lobe or inferior lobe, each lobe will be further subdivided into generally 3 sub lobe, 3 smaller lobes. So superior lobe, we have another superior lobe is made of 3 segments. Middle lobe will be made of, let's say, about 2 or 3 segments, and inferior lobe will be made of another 2, 3, 4, 5 segments. So there are more segments inside the superior, middle, and inferior lobe. So that is what we call the bronchopulmonary segment. So our trachea coming down from the laryngopharynx, larynx, trachea. This trachea we divide into right trachea and left trachea. And that is what we call, we are not going to call trachea anymore, the division of the trachea. And bronchi, yeah, we said main bronchi or primary bronchi. So right main bronchi and left main bronchi. Don't forget, right main bronchi is more vertical and left main bronchi is a little bit more horizontal. Yeah, so this is the right main bronchi, which is coming from the trachea. It is more like a vertical, and left main bronchi is slightly going more horizontal. Why is that? Because we have the heart more on the left side. So this division of the trachea is called carina, C-A-R-I-N-A. Carina is the division of the trachea, which divides into right main bronchi and left main bronchi. So the right main bronchi, of course, we have 3 lobes in the right lung, superior, middle, and inferior. So we will say another bronchi. So this is primary bronchi. So we will say this is secondary bronchi. So to go to the superior lobe, to go to the middle lobe, we have another secondary bronchi for the middle lobe, and we will have secondary bronchi for the inferior lobe. The same thing, the primary bronchi or main bronchi will become the secondary bronchi for the superior lobe and secondary bronchi for the inferior lobe. And as I say, even inside each lobe, superior, middle, and inferior lobe, there are another segments, and which are apical segment, posterior segment, and anterior segment. So it will further divide into another 3 for each segment. So this bronchi is called tertiary bronchi. So primary bronchi or main bronchi for the lungs, secondary bronchi for the lobe, and tertiary bronchi for the segment, apical segment, posterior segment, and middle level, and so on and on and on. So in the right lung, we got 3 lobes. So superior lobe, we have 3 segments, apical, posterior, and anterior. In the middle lobe, we have medial and lateral segments. And in the inferior lobe, we get superior, anterior, basal, medial, basal, lateral, base, posterior, basal lobe. So there will be 5 tertiary bronchi in the right lung. So that's, the same thing, similar, not identical on the left side. So that's the way we divide. So that is the easier diagram. So I want you to draw that. From the trachea we divide at the carina, C-A-R-I-N-A. And, I didn't record it, I think. So the trachea, the main trachea, we divide at the carina, C-A-R-I-N-A, carina, into right and left primary bronchi. So the right primary bronchi is for the right length. The left primary bronchi is for the left length, the whole length. And this right length has 3 lobes, superior, middle, and inferior. So the right main bronchus we have to further divide into 3 bronchi. So this is what we call secondary bronchi. The secondary bronchi for the upper lobe, secondary bronchi for the middle lobe, secondary bronchi for the lower lobe. And this secondary bronchi further divide into segments. So 3 segments for the superior lobes, we get 3 tertiary bronchi, 2 tertiary bronchi for the middle lobe, and 5 tertiary bronchi for the lower lobe. So the same thing on the left side, we got primary, secondary, and tertiary bronchi. So when the bronchi is called bronchiole, when they become less than 1 millimeter. Hey, this less 1 millimeter is so tiny already, less than 1 millimeter. So okay, we will not call any longer bronchi, we will say bronchiole. That's the diameter of the bronchiole. So any structure less than 1 millimeter, we will say bronchiole. Of course, this trachea, the bronchi, primary or main bronchi, secondary bronchi, tertiary bronchi, they are all filled with air, isn't it? So look at that. And then finally, our trachea became on the left side. This is the primary bronchi or main bronchi coming into the lungs. This main bronchi will split into 1 secondary bronchi for the superior lobe and another secondary bronchi for the lower lobe. And this secondary bronchi will go into the tertiary bronchi. So the same thing will happen in the lower lobe. And finally, when the diameter became very small, less than 1 millimeter, we will say bronchiole. Bronchiole we divide into terminal bronchiole. Hey, I'm going to finish. It is terminal. Not yet. Terminal bronchiole we further divide into respiratory bronchiole. So bronchiole, terminal bronchiole, and respiratory bronchiole. So I believe you have heard about bronchiolitis. So this happened in children, like little babies, like maybe about 2 years old, younger than that. Like this inflammation of the little bronchiole, how difficult it is. This baby is suffering. Less than 1 millimeter tube is getting inflamed and getting blocked. How difficult it is to take a deep breath in. They cannot, they are struggling. That is what we call bronchiolitis. So this bronchiole will become terminal bronchiole, then respiratory bronchiole, little respiratory bronchiole, and then finally it's branch up like a grapes. So a bunch of grapes is called alveolar sac. This alveolar sac is made of multiple alveolus. So ALVEOLUS is the one structure, one bubble structure. Multiple alveolus is called alveoli. So this a group of alveoli is called alveolar sac. So that's the way, it's just branch. And finally, alveolar deck. So bronchiole will become alveolar deck. A multiple is called alveolar sac, but let's say alveolar deck, finally we branch into alveoli. Multiple alveoli is called alveolar sac. Okay, so of course there is a space between this alveolar sac and this alveolar sac. Between this terminal bronchiole, respiratory bronchiole, there will be spaces. These spaces are filled with the collagen and elastin so that it gives the form and structure and elasticity of the lungs. Of course, when these airway expand, these elastic fibers will give dilation. And then we give space for dilation. And when you breathe out, these elastic fibers will go back and squeeze the little alveoli again. So these little spaces in between the alveolar sac or the respiratory bronchiole or the terminal bronchiole, these space will be filled with the elastin and connective tissue fibers, which give the structure of the lung and elastic required of the lung. So let's keep looking at this area. This alveoli, the blood coming from the heart will go around the alveoli. Look at that honeycomb appearance. So as I say, these alveoli, multiple alveoli in our lungs, multiple, and we said the surface area of this alveoli is about 1,500 square feet. So that is bigger than my house. Yes, square feet. My house is little. So I live in a little tiny box. So this is 1,500 square feet surface area. So that way, enrich this surface area to contact with the air and the blood. So this alveoli. So that is the alveoli here. So these alveoli are wrapped with the blood vessels. Of course, they are terminal blood vessels, which are called capillaries. So the deoxygenated blood will come and loop around the alveoli. For the blood, they want oxygen from the alveoli. And once they got the alveoli, they leave the alveoli and finally go back to the heart. Yeah. So let's try to look at this relationship between the alveoli and the capillaries for the lungs. So look at that. This is one alveoli. The alveolus. This is another alveolus. This is another alveolus. Another alveolus. And a multiple alveolus is called alveoli. And look at that. We can see the alveoli is very small, and the blood vessels, look at that here, they are lying in between the alveoli, multiple alveoli. So multiple alveoli, and the wall of the alveoli is very thin and flimsy. We said it is less than 15 times the thickness of the tissue. It is really, really thin. How can they make it? The nature. So the wall of the alveoli is very, very thin, 0.05. So micrometer thickness. So it is really, really thin. So only then, this exchange can happen between the capillary and the alveoli. So now we can see alveoli. Of course, this thin layer, it needs to be covered with the squamous epithelium, isn't it? Squamous epithelium, thin and flat cell. So in one layer, you cannot protect diffusion. So that will allow the diffusion across the membrane. That is the beauty of the squamous epithelium in one layer. So simple squamous epithelium. Simple squamous epithelium. Of course, in the respiratory tract, we will not say simple squamous epithelium. We will say alveolar cell, because it is inside the alveoli. So this is type 1 alveolar cell. Type 1 alveolar cell is nothing more than the simple squamous epithelium. So these are thin and flimsy, simple squamous epithelium, and we can see, if we say type 1, of course, we have type 2 alveolar cell, which is a little bit thicker, and sometimes they can even like a cuboidal epithelium, so a little bit thicker. So this way, the job of the type 2 alveolar cell is to secrete surfactant. Surfactant is the surface tension lowering agent. If someone is born before 34 weeks of pregnancy, so prematurity, the surfactants type 2 alveolar pneumocyte cells are not mature enough and they cannot make enough surfactant. Surfactant reduce the surface tension to keep the alveoli open. So if we do not have surfactant, this alveoli will collapse and the air cannot get to the alveoli and they cannot deliver oxygen into the capillary. So that is what we call respiratory distress syndrome. So this respiratory distress syndrome is in the neonate is because of the lack of surfactant, which is prematurity. Like, these cells are not mature and they cannot make enough surfactant. So let's look at the partition between the alveolar wall and the capillary wall. So this is the area we are going to focus. So this is the simple squamous epithelium. We said simple squamous epithelium is for the alveoli, and the cells are really, really thin and flimsy. Yeah. So let's look at the junction of the alveoli on one side and the capillary on the other side. Of course, it is simple squamous epithelium. We will say type 1 alveolar cell. So type 1 alveolar cell here. And of course, it is epithelium. So it has to rest on the basement membrane. Where is the basement membrane? Basement membrane is here, very thin and flimsy, guys. It is very thin and flimsy. And look at the capillaries. We know that capillaries are very lined with the very thin, simple squamous epithelium again, but we will not say simple squamous epithelium because it is capillary. So we will say endothelium. So this is the endothelium, which is the simple squamous epithelium side of the capillary. This is the type 1 pneumocyte, type 1 alveolar cell, which is the simple squamous epithelium from the alveolar side. And look at the partition. So one from the alveolar side, another simple squamous epithelium from the capillary side, and because these are the epithelial tissues, so they have to rest on the basement membrane. The basement membrane for each epithelium has fused and very thin and flimsy. The thickness is very, 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 very thin and flimsy. It is like 15 times, just about the thickness, 15 times thickness of the tissue paper. It is so thin and flimsy. Yeah, so that's the only way the oxygen from the alveoli can cross and go into the capillary blood, go to the RBC, and oxygen from the RBC can get delivered into the alveolus. It is really that's the structure we are not going to talk about now. So finally, so let's look at the bronchi, airway, trachea, divide into right and left main bronchi or primary bronchi. This is called carinal. If you look cross-section and look at the epithelial surface, of course, this trachea will be lined by pseudostratified columnar ciliated epithelium. Of course, that's the pseudostratified columnar ciliated epithelium. So all the bronchi, they are lined with the pseudostratified ciliated columnar epithelium. And look at the thoracic cage. If we take off all our clothes off, if we take off all our muscles off from the thoracic cage, and now we have the ribs, the sternum, the cartilage, and we do not have any more pectoralis muscle or any latissimus dorsi or trapezius. No more, no more, no more. Yeah. So we are looking at just the thoracic cage. We have the ribs, first rib, second rib, third rib, fourth, fifth, sixth, seventh. And the space between the first and second is called first intercostal space, second intercostal space, third intercostal space. And these intercostal spaces are filled with the muscles. So muscle extending from the first rib to second rib. This muscle extends from second rib to third rib. So these are in the intercostal space, and therefore we will call it intercostal muscles. Yeah, intercostal muscle in between the costal cartilage. And we said 3 intercostal muscles we have. Outermost is external intercostal, middle is internal intercostal, and innermost is innermost intercostal muscles. Yeah, so external intercostal muscle, the direction is going downwards and medially, like the way you put your hands in the pocket of the front pockets of the trouser. So downwards and medially. Internal intercostal, opposite direction, downwards and laterally. And innermost intercostal, which will follow the internal intercostal muscle, because it is too thin and flimsy already. So it just follow the nearby structure. So down it will follow the internal intercostal muscle. So external intercostal, internal intercostal, and the innermost intercostal. And these are the rib. These intercostal muscles come from the upper rib to the lower rib, upper rib to the lower rib. And that is the relationship between the neurovascular vessels. These are the intercostal neurovascular vessels. And don't forget the arrangement, VAN, vein, artery, and nerve. What does it mean? So if you put a chest tube in somebody's in the intercostal space, and if there is bleeding, significant bleeding, then you might think, hey, I have damaged the intercostal vein, which means if you have damaged the intercostal vein, you have damaged the intercostal nerve already. So that is the clinical significance. So of course, this venous bleeding, it is annoying. It is keep bleeding on and on and on. It will stop at some point. Doesn't really matter. But if we damage the vein, that means we have damaged the nerve already. And like if someone has rib fractures, if you want to give pain relief for the intercostal nerve, here we just inject just below the rib in the intercostal space close to the rib. And if we give local injection, this intercostal nerve will get blocked and the pain will get much better from the rib fracture. So here, look at that thoracic cavity, which is first rib, second rib, third rib, intercostal space filled with intercostal muscles, external intercostal, internal intercostal, and innermost intercostal. If you look at the very particular area, let's magnify this area. So this is the rib. In between the rib, we have the intercostal muscles. And after the intercostal muscle, we will have the pleura, yeah? Pleura, which lines the thoracic inner surface of the muscle, and this pleura will deflect and go back and covers the lung substance. So visceral pleura, which is covering the lungs, and parietal pleura, which is covering the inner aspect of the thorax. And there is a little potential space which is filled with the flimsy fluid. This space is called pleural cavity. So pleural cavity is usually just like a little flimsy. It is not open space. It is a potential space. And the lung sitting on the diaphragm, and this is the lung substance itself. This is the visceral pleura, and this is the parietal pleura, and this is the intercostal muscles and the rib. That is the relationship. So when you are putting a chest tube, so some of you guys work for emergency medical service, EMS team, or you might be working in the ER. So let's say if you have to put a chest tube in somebody, these are the structures you are passing through. Yeah, so you are passing the skin, of course, subcutaneous tissue, of course, and you will try to identify the intercostal muscle, split the intercostal muscle, and you perforate the parietal layer of the pleura, but you are not going to touch the visceral layer of the pleura. So because you want the tube in the pleural cavity, which is filled with air or water or blood. Yeah, so that is the space you are aiming for. You are not going to damage the visceral pleura, because viscera pleura is stacked to the lung substance itself. If you damage the viscera pleura, you will damage the lung substance, and that is another problem. Okay, let's move on. So that is the ribs, intercostal muscle. This is the lung substance itself. I'm just exaggerating. This is the visceral pleura, which is stacked on the lung, and parietal pleura, which is stacked on the thoracic wall. This space is called pleural cavity. It is just a pleural, it's just a potential space. It is not open like this. I'm just exaggerating with the diagram. And here is the pneumothorax. Pneumothorax means air in the pleural cavity. And if the air is significant enough, it will collapse, it will squeeze the lungs down, it will press on the lungs, and then the lungs will collapse. Now the left lung is fully expanded, right lung is collapsed already because the pleural cavity is filled with air. Air in the pleural cavity is called pneumo means air, thorax, pneumothorax. So let's say if the collection is not air, if the collection is blood, then we will say hemothorax. If the collection fluid is chyle, then we will say chylothorax. So the aim of our chest tube is to sit in the pleural cavity where there is air or the blood or the chyle is. So once we drain the air out, and the lungs, because of the air we breathe in, the lungs can gradually expand, and push out the air, and the pleural cavity is filled with the lungs again. Now it is fully re-expanded lung. So this is the diaphragm. I'm not going to waste time on that. And the thoracic cavity, we have talked about the boundaries of the thoracic cavity. I believe everyone is easy with that. And function of the thoracic cavity is not rocket science. It's for protection, it's for respiration, it's for support the upper limb, and it is for muscle attachment. So this is pretty easy topic. So osteology of the thorax, we have talked about that already. And this is the mediastinum and diaphragm keep coming in. And don't forget, diaphragms are dome shaped. This is the right diaphragm, this is the left diaphragm, this is the space for the heart. We are looking from the top to the bottom. This is the posterior aspect because we can see the vertebral body. This is the sternum here, right dome of the diaphragm, left dome of the diaphragm, and diaphragm is a dome shape. So one dome on the right, another dome on the left. So each dome shape. When the diaphragm contracts, it just flattens out. Yeah. So this is a diaphragm. Don't forget, it is made of fibromuscular structure. In the periphery, it has muscle. In the center, it is more like fibrous tendinous structure. So thoracic vertebrae, I believe you know already. And this is the simple diagram. So vertebral body, pedicle, lamina, going transverse. So transverse process, going to the back, spinous process. Okay, let's move on. So the ribs, we know that already. We know that. So the ribs, true ribs, false rib. Let's move on. And these are the muscle attachment. So external intercostal, internal costal, innermost intercostal. There is one more layer, which our textbook doesn't mention. And the diaphragm. Of course, these muscles will become important with the muscle of respiration. So look at this diagram. It is showing the relationship between the lung substance itself and the pleura. So pleura, as we know, it is just covering the lung. It is like our blanket. So our blanket will extend beyond our body. So the same thing, the pleura will extend beyond the lung substance. So the whole lung is covered with the pleura, and the pleura will extend even more. Look at that. This is the lung stop here, and the pleura extend beyond the lungs. So if you look from the back as well, that is the end of the lung substance, but the pleura will extend beyond the lung. So that is, so when we breathe in, the lung will expand so that there is still room for the pleura to accommodate the lung substance, which is filled with the air. So inspiration, if we breathe in, what we do, so our external intercostal muscle, we pull the ribs outwards and laterally. Yeah. So, and if you look from the front, the external intercostal muscle, we pull the ribs upwards and laterally. If you look from the side, the muscle, the sternum will be pulled upwards. So that is look at the direction of the external intercostal and internal intercostal muscle. So the ribs, so these muscles contract and the ribs will be pulled upwards and laterally. So that is, we try to appreciate this as a Beckett handle movement of the thoracic cage, because the ribs are coming from here, going up here. So upwards and laterally, upwards and laterally, upwards and laterally. And so at the same time, if you look from the side, the ribs are opening outwards and laterally. When they do that, they lift up the sternum upwards and forwards, upwards and forwards, upwards and forwards. So if you look from the side, it is look like a pump handle. Yeah, you are taking water out of the ground. Pump handle movement if you look from the side. And if you look from the front, you are looking like a Beckett handle movement. So I want you to appreciate these pump handle movement and Beckett handle movement. Why does it happen? Of course, the external intercostal muscle, they are contracting. The muscle which is coming downwards and medially, when they contract, they will go backwards and outwards. So therefore, it will extend. So what does it do? This internal intercostal muscle. Internal intercostal muscle will support the external intercostal muscle. So that is the inspiration, which is an active effort. We have to expand the thoracic cavity. So because this pump handle movement and Beckett handle movement will increase the anterior and posterior diameter, will increase the lateral diameter. And at the same time, when we with the inspiration, our dome-shaped diaphragm on the right will go flatten, our dome-shaped diaphragm on the left will go flatten. That increase the vertical diameter of the thoracic cage. So next time, when you take a deep breath in, try to think yourself, you are expanding the chest wall, AP diameter, lateral diameter, and at the same time, you are pushing down the abdominal viscera with the diaphragm. So this thoracic cavity expands. Because of the expansion of the thoracic cavity, they will create negative intrathoracic pressure comparing to the surrounding atmosphere. And therefore, the air from the atmosphere can go into the less pressure area inside the thorax. Therefore, we can take a breath. But what we have to do is we have to expand the thoracic cavity. Therefore, the inspiration is active process. Look at these muscles here. That is our pectoralis major muscle, which is on our chest. And if we remove the pectoralis major, we can see the smaller muscle just underneath the pectoralis major. Therefore, we will say pectoralis minor. So pectoralis minor is underneath the pectoralis major, which is attaching to the ribs, to the coracoid process of the scapula. Yeah, coracoid process of the scapula. So look at that pectoralis minor. It is arising from the this is second rib, so 3, 4, 5. So from 3, 4, 5 ribs going to the coracoid process of the scapula. And look at the sternocleidomastoid muscle. This is the muscle in our neck. This is the muscle in our neck, which is here, coming from the mastoid process to the sternum and the clavicle. So sternum and clavicle, sternocleidomastoid. Mastoid means mastoid process. That is the process at the back of our ear. So this muscle, sternocleidomastoid, and this pectoralis major. What is the importance? Of course, with the normal inspiration, we will use only external intercostal muscle and we use the diaphragm. So hey, it's easy. But if someone is just like breathless and struggling for a breath, then these external intercostal and diaphragm alone cannot work anymore. So they have to ask these muscles, sternocleidomastoid muscle and pectoralis minor muscle, hey, help me to pull the rib cage, help me to pull the sternum forward. So these sternocleidomastoid muscle and pectoralis muscle, they have to get involved when we are making a big effort. So effort, breathe inspiration. Active, struggling inspiration, we will ask these sternocleidomastoid muscle and the pectoralis minor muscle to expand the length. Pectoralis minor muscle, we pull the ribs outwards. The sternocleidomastoid muscle, we pull the sternum forward. Hey, try help. The external intercostal cannot do the job anymore. Yeah, diaphragm is not working anymore. So that is the way, which is the active effort inspiration. Yeah, this is normal inspiration. It's just external intercostal and the diaphragm. So look at the back of our body. I'm just keep showing you again and again this big trapezius muscle and this big lower latissimus dorsi muscle. That is, these muscles we cover the posterior aspect of the thoracic cavity. And when we talk about respiration, I want you to think in a many different steps. So the air inspiration, let's say respiration, inspiration means we take a deep breath in, the air we breathe in, we have to go through the nose, through the nasopharynx, oropharynx, laryngopharynx, go into the larynx, go into the trachea. Trachea, we divide into right bronchi, left bronchi, main bronchi. We divide into secondary bronchi, tertiary bronchi, finally become alveoli, alveolar duct, alveolar sac. So the pulmonary ventilation means the air is going into the lung, going out of the lung. That is what we call pulmonary ventilation. External respiration means the transfer of oxygen into the blood capillary. And then the respiratory gas transport means this blood will carry the oxygen to the cell. And internal respiration means the oxygen from the blood will go into the cell. So oxygen will get into the cell. And then finally, cellular respiration, the cell mitochondria is using that oxygen delivered by the blood and generating energy. That is the cellular respiration. So that is a multiple process which need to get it right, for us to stay like you and me. Yeah. So if there is any problem, we will get into trouble. And we talk about the hypoxia and hypoxemia. Hypoxia is the state of reduced oxygen in the tissue. Hypoxemia, emia is in the blood. So hypoxemia means reduced oxygen in the blood. And the 4 different types of hypoxia, which I want you to remember, which is really, really, really important. Inspiration, normal quiet inspiration, our diaphragm and intercostal, only these muscles work. We don't need pectoralis minor. We don't need sternocleidomastoid. The way we breathe in, pump handle, bucket handle movement created by the external and internal intercostal muscle. And the vertical diameter of the thoracic wall will be increased with the dome-shaped diaphragms on the right and on the left. So diaphragm here One, it is in the resting stage. It is like a dome shape, right diaphragm, right hemidiaphragm, left diaphragm, which is left hemidiaphragm. While there is a contraction, that the diaphragm will become flattened out, which increase the AP diameter of the thorax. So when you are during your inspiration period, you are trying to expand your thoracic cavity in many different directions, laterally, AP and posteriorly, anterior and posteriorly, and vertically as well. So that's the way we create the negative pressure inside the thorax, negative intrathoracic pressure, and the atmospheric air can go into the lung. So of course, for us to do inspiration, the diaphragm need to contract, and this diaphragm is supplied by the nerve, which is the nerve supplied to the diaphragm is phrenic nerve, which is arising from the cervical 3, 4, 5. So the cervical 3, 4, 5 will keep your diaphragm alive. So C3, 4, 5 keep your diaphragm alive. C3, 4, 5 keep your diaphragm alive. C3, 4, 5 cervical nerve, the nerve coming out from the cervical spine, 3 cervical spine, 4 cervical spine, 5. They will combine together to form the phrenic nerve, will keep your diaphragm alive. So they will keep the diaphragm moving. So therefore, if somebody has got cervical 3, cervical 4, cervical spine injury, and if the injury involves the cervical 3, 4, 5 level, they are phrenic nerve gone. Hey, they cannot breathe on their own. They will need respiratory support. So that is the importance. Phrenic nerve, dome shape, flatten when it contracts, and increase the vertical diameter of the diaphragm. So this is easy now. So hey, it is one hour already. So external intercostal muscles, they are supplied. These muscles are supplied by the intercostal nerve. Of course, it is very closely related. Its contraction, we lift up the ribs outwards and laterally. We take the sternum upwards and forward. So it increases the AP and lateral diameter. Internal intercostal muscle, they just support the external intercostal. So external intercostal is more important for the inspiration. Yeah, so Becker handle and pump handle movement. So increase in size of the thorax. So once we contract the diaphragm and the external intercostal muscles, the thoracic cavity size increase. Increase in size of the thoracic cavity, increase the size of the pleural cavity, and create negative intrathoracic pressure. Air from atmosphere can enter into the lungs. So lungs are directly connected to the nasal passage, but the pleura is just an outer blanket. Yeah, so the pleura is nothing to do with the air we breathe in. It just covers the lung in 2 layers. Okay, so this is the lung, which is might be about 8 ribs. It's just stop here, but the pleural cavity will extend far beyond the lung at to about 10 or 9 intercostal space here. And at the back, we saw that the lung stop here at the 8th rib, but the pleura will go extend at about 12 ribs. So this because of that, the inside of the pleura, the lungs can expand inside the pleura. So let's say forceful inspiration, we are struggling for breath for someone who is having asthmatic attack. And we said the external intercostal and diaphragm alone, they cannot do the job anymore. So they have to ask for the sternocleidomastoid, scalene muscles, and pectoralis minor muscle to to help to expand the thoracic cavity. So that is for forceful inspiration. So in forceful inspiration, these muscles gets into play, but normal quiet respiration, they don't really need to. So look at that, sternocleidomastoid muscles. Sterno means sternum, cleido means clavicle. They go together to go to the mastoid process, sternocleidomastoid muscle. Scalene muscles are the deep muscles inside the neck around here. Just you have to remove the sternocleidomastoid to get to the scalene muscle. So these muscles and the pectoralis minor, which you saw, they work together to form the to help with the forceful inspiration. So expiration, it is a passive process. So you don't need to do much. You stop breathing in. The elastic required of our lungs. So the elastic fibers, collagen fibers around the alveoli, around the thoracic wall, we just gradually go back and relax. And by doing so, it will squeeze the air out from the lungs, from the alveoli into the trachea and go out. So that is the inspiration and expiration. Inspiration, breathing in, is active process. Forceful inspiration, you have to use more muscle, but expiration, you just relax. Elastic required, we squeeze the air out of the lungs. So let's say if you are forced expiration, you are trying to force and it is an active process now. Your abdominal muscle will contract and your increase in abdominal pressure because you are contracting the abdominal muscle. Then this contraction will push the diaphragm upwards. So just make the thoracic volume smaller. So just try to squeeze the lung out from many different angles. And it depresses the rib cage as well. So quadratus lumborum muscle, we pull the ribs down. So this is for the forceful expiration. So look at the abdominal muscle here, which we will talk about in detail when we talk about abdomen and the gastrointestinal tract. So these are the arrangement. Hey, how many abdominal muscles do we have? How many layers? We have 3 layers, which is external oblique, because they are coming running down. So external oblique, the same direction as the external intercostal muscle. Internal oblique, downwards and laterally, so the same like internal intercostal muscle. And innermost intercostal, so we don't have innermost abdominis, but we will say transversus abdominis. They are going transverse direction. So these are the abdominal muscles together with our rectus on the right side, rectus on the left side, which has been removed, which hasn't been removed here. So rectus on the right, rectus on the left. These abdominal muscles will squeeze the tummy hard. Then the diaphragm will go upward, being pushed out, and it will squeeze off the air from the lungs. So if you look at these muscles, then that is the arrangement. This is the rectus on the right. This is the rectus on the left. These are the external intercostal, internal intercostal, and transversus abdominis muscles. So these muscles will contract to squeeze the abdomen. So now we go back to our lungs in little delicate thin structures, alveolus, alveolar duct, and alveolar sac. And these are the dimensions here. Diameter of alveolus. So look at these diameter of the alveolus, like 0.2 millimeter. You don't need to know that, but it's just because of the lecture, and 400 millions of air-filled alveoli at any time. And it is the 40 times greater than surface area of skin. So it is excessive. Yeah, the surface area of the alveoli is enormous. So because of this great surface area, we get all the oxygen we need for the whole body. So if you think about one lung itself, right lung, left lung, what is the weight of the lungs? They are about like twice the size, twice the weight of the heart. So let's say about 600 grams. The heart is about 300. The lungs, each lung is about 600. So that's the weight. So, you know, inside the lungs, we fill the lung with the air. We fill up the lungs with the air inside the alveoli. So that will also help with the buoyancy. So for those people who can float on the water, that is the buoyancy. If we just take a deep breath in to the lungs and hold it, the lungs will act as like a life jacket, because it creates the buoyancy as well. Okay, let's move on. Alveoli remain open at all times. Surfactant secreted by type 2 pneumocyte. It reduces the surface tension. What is surfactant? Surfactant is nothing more than phospholipid. So amino acid and some lipid. That's all. But it really plays an important role in our alveoli. Yeah. So surfactant is made from the type 2 alveolar cell. And when we talk about surfactant and alveoli, this little alveoli, which is the diameter of the alveolus is 0.2 millimeter. Hey, it is so small. How can keep it open when we exhale all the air out of the lungs? So expiration, forced expiration, you are forcing the air out with the abdominal muscle, squeezing the lung. How can this little alveoli remain patent and open? It is because of the law of Laplace. Law of Laplace, it's said the pressure is related to tension over radius. So pressure is directly related to tension, and radius is inversely related to the pressure. Of course, pressure means pressure inside the alveoli. Tension means the squeezing pressure, which makes the alveoli collapse, which is tension. Tension is directly related to the pressure, and radius is inversely related to the pressure. That is the law of Laplace, which explains this little tiny alveoli remains open even when during the expiration. So who is Laplace? Law of Laplace. This is the French scientist. Law of Laplace. The French scientist, what he say is like, if you look at this, you know, the law of Laplace, Andrew Brinks, that's from the, I think, Virginia Tech University. He explained it really well. So, and this is the easy way to remember, the radius is inversely proportional to the pressure. So the smaller the radius, the inside pressure is bigger. The smaller the radius, inside pressure is bigger, and the bigger the radius, the inside pressure is lower. That is the way the air-contained structures like lungs, our alveoli, our bronchioles, our trachea, they do not collapse. It is because of the law of Laplace. So alveolus, the little minute details about the alveolus. Diameter is 0.2 millimeter. There are about 400 million, such a lot of alveoli in our lungs. AFA alveoli, 40 times greater than surface area, greater than 40 times of the skin. It has got elastic fiber, alveolar pore. We saw the alveolar pores and alveolar macrophage. Where are the alveolar pores? So these are the little pores here on the wall of the alveoli. What does it do? This alveolar pore will contact one alveoli to another alveoli through the small little pores, so that they can adjust the air pressure among each other. Yeah. So the alveolar pores will contact and perforate through the alveolar wall and connect to the other alveoli. So that is the lungs, and this is this is what we have talked about. So that is pretty detailed and which is really nice. So this is the deoxygenated blood, which is carried by the capillary. Deoxygenated blood comes along the capillary, which is wrapping around the alveoli. And during so, the carbon dioxide from the blood will leave the capillary and will diffuse into the alveoli as the capillaries goes along. And the oxygen from the alveoli will diffuse into the blood, and the blood will gradually become red and red, more oxygenated, and leave the alveoli. Look at that, this alveolar, type 1 alveolar cell, they are flat thin cell, which is only simple squamous epithelium, Type 1 pneumocytes are thin flat cell, which allows the gas exchange. Look at the type 2 pneumocyte, which is the big cells here. Type 2 pneumocyte secrete this surfactant. Type 2 pneumocyte, it is much thicker. They will secrete surfactant into the alveoli, which is the surface tension reducing agent, which is like a detergent to keep the little alveoli remain open and patent. That is the beautiful things about our lungs. So now we have seen this again and again already, but I'm going to remind you again, bronchial less than 1 millimeter, terminal bronchial, alveolar deck, alveolar sac, and respiratory bronchial. And now, hey, it is nearly end of the lecture, but not over yet. How do we control our respiration? Oh my God. It is autonomous, isn't it? Because when we are sleeping, we don't know anything about the environment. We are stay breathing. So during sleep, we are breathing. And when we are talking to each other, we are stay breathing. So what is that? There must be an autonomic function. So this autonomic process of breathing, it comes from the medulla. This is called ventral, V, respiratory for respiration. From the ventral respiratory nucleus, ganglions, in the medulla, they are discharging impulses to the phrenic nerve and to the muscles for the to the intercostal nerves, intercostal muscles. So this ventral respiratory group of nuclei, this ventral respiratory group, which is located in the brainstem medulla, they are discharging impulses spontaneously almost all the time. And therefore, we are breathing without awareness. That is the spontaneous process. Ventral respiratory group of nuclei in the medulla. So medulla is part of the brainstem. The brainstem has got three portions: midbrain, pons, and medulla. So midbrain, pons, medulla, midbrain, pons, medulla, midbrain, pons, medulla. So this ventral respiratory group is in the medulla. And of course, those neurons from the pons will also come to the medulla and just try to regulate and make the respiration smooth. So therefore, brainstem is really important for our respiration. And if there is any stroke, for example, brainstem stroke, it's really, really deadly. It is fatal. It can be fatal because it is going to disturb our respiration. It is going to disturb our heart because cardio-inhibitory center and all these, they are all in the brainstem. So the brainstem damage is fatal. So the ventral respiratory group is in the brain, and medulla is in the brainstem. Brainstem has got three portions: midbrain, pons, and medulla. And here, medulla, ventral respiratory group, and limbic and hypothalamus area. Hypothalamus, we saw that already. It is part of the brain, limbic part of the brain. And limbic and hypothalamus, of course, because it is related to the brain, it is emotion. If we are stressed, our respiration rate will change. So emotion, anxiety, stress will change our respiratory rate through the limbic system and hypothalamus. And our cerebral cortex as well. So the brain, parietal cortex, see cerebral cortex, we can make an effort. That is just like, voluntary, active. I'm just making it up. So that this side of respiration, increase in respiratory rate coming from the respiratory group as well. And of course, chemoreceptors. So all the receptors for the chemical changes in the blood, like for example, like hydrogen ion changes, carbon dioxide changes in our blood. So hydrogen ion, carbon dioxide, these changes are detected in the blood, detected by the chemoreceptors for the respiration. These chemoreceptors are located in the aortic arch or bifurcation of the carotid. So carotid body, aortic bodies, these little structures which sense the chemical changes inside the blood will also influence on the rate of respiration. So that is the way, many different ways to control our respiration. So of course, spontaneous respiration is ventral respiratory group. The next is limbic and hypothalamus, which is for emotion, stress and anxiety change our respiration. Voluntary effort, you can just make it up. Chemoreceptor chemical changes in our blood will be detected by these chemoreceptors. These chemoreceptors are located in the aortic bodies, carotid bodies, and they will change the respiration. So yes, that is what we talk about. The brainstem is made of midbrain, pons, and medulla oblongata. We were talking about VRG, ventral respiratory group, which is located in the medulla. Where is medulla? Medulla here. This is the ventral respiratory group. They send the impulses to the intercostal nerve and to the phrenic nerve for the respiration. Of course, those nucleus from the pons region will also come and influence on the medulla to make the respiration smooth. So that is this respiratory center, ventral respiratory group, is the pacemaker of the respiration. Yeah. So this is what am I showing about? Oh, this is the brainstem. Brainstem, this is the brain cortex, cerebral cortex. This is the cerebellum, and this is the brainstem, which is made of midbrain, pons, and medulla oblongata. So midbrain and pons, medulla oblongata. Medulla oblongata has our ventral respiratory group, which we come and give impulse to the diaphragm via the phrenic nerve to the intercostal muscles and through the intercostal nerve. So that is the way we do our respiration. Other structures that control the respiration: limbic, cerebral cortex, and the chemoreceptor. So what am I going to show? Of course, I'm going to show you the chemoreceptor. Yeah, you can see the aortic arch here. So the chemoreceptors, aortic bodies will be located here. Oh yeah, aortic bodies will be somewhere around here in the aortic arch. Carotid body will be at the bifurcation. Common carotid artery will divide into internal carotid and external carotid. External carotid and internal carotid. At the bifurcation, we have the carotid bodies. So these bodies will detect the chemical changes, especially hydrogen ion changes in our blood, and they will trigger the respiratory changes. So asthma. So what is asthma? Of course, it is this little airway, small alveoli, before alveoli, bronchial, small airway obstruction, intermittent, reversible. It is reversible. If you keep medication, it will just dilate again. Small airway obstruction. So risk factor for asthma, that is what we saw. We know atopy, like allergy, family history, smoking, obesity, and air pollution. These all can contribute to the asthma. So cystic fibrosis, I believe you have heard of it. Cystic fibrosis, it is a big problem. It affects the Caucasian population. It is autosomal recessive. So it damages the respiratory tract, sweat, gastrointestinal tract, and exocrine pancreas as well. So let's look at a few X-ray. This is the normal length chest X-ray. Now you know the heart. You know the heart. Right border of the heart made of right atrium. Inferior border and apex of the heart made of left ventricle. Anterior surface of the heart made of right ventricle. And left atrium will be somewhere around here, very small from the front. And these are the lungs here. Lungs are filled with air, and therefore the X-ray beam can easily go through the lung, and it is more dark. The bones, which are filled with calcium, X-ray beam cannot go through easily, and therefore they are more white. So here the lungs are black and nice and black. And here, look at that, the lungs, the shadow, lung shadows are, bronchial shadows are a little bit dilated and more prominent here. The lung is not as dark as this normal lung because these alveoli, they are damaged. They damage the elastic fibers near the alveoli, they are damaged. And it is no longer properly air-filled alveoli. And therefore, the lung is very expanded with the, not a properly arranged air in the alveoli. It is everywhere. And that is the emphysema. It's a condition where the lungs alveoli with the associated elastic fibers, they all damaged. That is emphysema. Let's look at next. So the lung here, the right lung has collapsed to a very small amount. They should be around here, down to the 8th rib. And now this lung is collapsed. Why does it collapse? Because in the pleural cavity, between the parietal pleura and visceral pleura, the fluid accumulate. That is what we call pleural effusion. The fluid in the pleural cavity, pleural effusion, it just impedes the lung, push the lung and squeeze the lung to make it small. The lungs cannot expand anymore with air because the loss of fluid in the pleural cavity. That is what we call pleural effusion. Let's look at that pneumothorax. Look at the left lung, which is the lung shadows are everywhere throughout the lung. On the right side, the lung substance has collapsed here. Look at the lung substance here. And the pleural cavity is filled with air, a bit darker. You cannot see any more lung shadow like here. That is what, because the air inside the air inside the pleural cavity is crushing the lung substance down. That is what we call pneumothorax. Yeah. So look at that, this chest X-ray. If you look at that, the left lung, it is not too bad, but comparing to our normal chest X-ray lungs, the shadows are a little bit more. But on the right, it is quite a lot of shadow here. So the upper lobe looks okay, but middle lobe looks very hazy and dense. That is the lobar pneumonia. Lobar pneumonia means affecting the middle lobe of the lungs. So that is the pneumonia, the typical lobar pneumonia, which is affecting the right lobe of the lung. That is the lobar pneumonia. In pneumonia, the alveoli are filled with the mucus and all the inflammatory exudates, inflammatory fluids. The alveoli is no longer filled with air. The alveoli filled with the inflammatory fluids like bacteria, inflammatory cells, mucus, all filled. Therefore, the whole lobe of the lung looks like that on the X-ray. So the bronchitis and emphysema, of course, for those people who smoke or air pollution is bad, then this smoke we go and damage the nasal epithelium along the oropharynx, larynx, trachea, bronchi, bronchioles. So these bronchi, bronchioles, they are lined by pseudostratified columnar ciliated. So that the secret smoke will damage the cilia. So there is no more effective removal of the dust and pollution from the lungs, bronchial epithelium. The glands in the columnar epithelium will become bigger because of the respiratory irritants, and they will secrete more mucus, and that's the hypertrophy. So the glands will get bigger and bigger. So that is chronic bronchitis, excessive mucus production, chronic cough, and destruction of the alveoli wall. So this little alveoli wall, which is just about 0.2 millimeter size, which is the alveolar wall is lined with the type 2 pneumocyte and type 1 pneumocyte. They will all get damaged with the smoke we inhale. And these elastic fibers damage. And finally, that is what we call emphysema. So chronic bronchitis, emphysema, together we call COPD, yeah, chronic obstructive pulmonary disease. Right, that is the near end of the lecture. Let's go back to a little bit bits and bobs. Bronchopulmonary segment. Bronchopulmonary segment is the portion of the lung which is supplied by the tertiary bronchiole and its own artery, its own vein structure. So portion of the lung supplied by specific segmented bronchus, artery and vein and lymphatics. So this is what bronchopulmonary segment. So yeah, so this airway, tertiary bronchus, is called segmented bronchus. It will go to the apical bronchopulmonary segment. This airway will go to the posterior bronchopulmonary segment. This airway will go to the anterior bronchopulmonary segment. So it is just like the whole lungs, which is like a block of apartments. And this is the bronchopulmonary segments are single particular apartment. Yeah. So this is the big block of building as a lung. This one bronchopulmonary segment is the individual apartments inside the big building. So that's all. The one segment is separated from another segment with the connective tissue. So the good thing is, if there is infection in the apical bronchopulmonary segment, we can only take the apical lobe off. If there is any cancer in the apical segment of the right lung, superior lobe, then we can only take the apical portion of the lung. So that is the good. So infection will get tried to contain as much as possible in each and individual segment. If not, go into the each and individual lobe. Yeah, that is the way the human body try to contain infection. So these are the bronchopulmonary segment. I do not expect you to remember all the details about the bronchopulmonary segment, but I want you to remember right lung has got 3 lobes, left lung has got 2 lobes, and right lung's 3 lobes with superior lobe of the lung, we have 3 bronchopulmonary segment. Middle lobe of the right lungs, we have 2 bronchopulmonary segment, and inferior lobe, we have 5 bronchopulmonary segment. So on the left side, we only have 2 lobes, therefore we will split into the superior lobe and inferior lobe, and these are the bronchopulmonary segments for the superior lobe, and this is for the inferior lobe. If you read carefully, it is just like very, very, very similar. But I want you to appreciate there will be like how many 10 bronchopulmonary segment in the right lung, and there might be about 9 or 10 in the left bronchopulmonary segment. The importance of the bronchopulmonary segment is it tries to contain infection or cancer in one segment, so that if there is any problem, we don't need to remove the whole right superior lobe. We can only remove the particular apical lobe or posterior lobe, or might be apical and posterior lobe, and we can leave the anterior lobe, because one segment and another segment are partitioned with the connective tissue properly. Yeah, so getting close to the end, this is a slide which you do not want to see anymore. You have, because you know this already. Lobe, 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 and fissure, fissures, fissures. You know that already. Bronchopulmonary segment. And let's look at the length from the medial side of the length. This is the, not the costal cartilage. This is the medial side of the length. You can see the pulmonary artery, pulmonary vein, and bronchus going into the lung. And this area is called hilum of the lung. Yeah, so all the artery, veins, and bronchus going into the lung. This area is called hilum of the lung. Upper respiratory tract extends from the nose to the larynx, and lower respiratory tract extends from trachea to the alveoli. Yeah, so lower respiratory tract and upper respiratory tract. What is the difference? Of course, if you want to describe someone having upper respiratory tract infection or lower respiratory tract infection, the larynx is the cutting point. Larynx and above is upper respiratory tract. So nasal sinus infection is upper respiratory tract. Laryngitis, pharyngitis is upper respiratory tract. But tracheitis, inflammation of the trachea, and downwards down to the alveoli, it is the lower respiratory tract. Just trying to explain this pharynx. And this is what you all know about already. This is the bridge of the nose. This is the apex of the nose. This is the nostril, the aperture where the air go into the lung. And this little outside of the nose is called ala of the nose. So yes, the part of the nose is made of bone, and the distal part of the nose is made of cartilage. Yeah, so it is the nose is made of both bone and the cartilage. Nasal cavity, we have talked about that already. The roof of the nose is ethmoid bone and sphenoid bone. The floor is palate, half palate, and soft palate. We know that posterior nasal aperture separated into half by nasal septum and pseudo-stratifying columnar ciliated epithelium. That is easy now. So that is, we have seen this already. This is the right nasal cavity. This is the left nasal cavity separated by the internasal septum. Inside the nose, we have superior, middle, and inferior conchae. Which increase the surface area. This is the sagittal view, superior concave, middle concave, and inferior concave. Underneath the area underneath the concave is called nasal meatus. It is just to increase the surface area inside the nose. The pharyngotympanic membrane, which you have seen is already at the back of the nasal cavity. If you follow this track, pharyngotympanic membrane, you will get to the middle ear cavity. Its job is to balance the air pressure inside the ear with the atmospheric pressure. And paranasal sinuses, look at that. The face on either side of the nose, on the maxillary bone, we will say maxillary sinus. Yeah, so this is the CT scan coronal view. This is on either side of the nose. That is called maxillary sinus. And look at the base of the nose, sphenoid sinus. Here, look at that sphenoid sinus. And just on each and off of the right and left eye, this is the ethmoid sinus. Ethmoid sinus here, and just around the eyebrow, medially, it is frontal sinus. Frontal sinus, ethmoid sinus, sphenoid sinus here, and maxillary sinus. So if someone has sinusitis, that means inflammation of the lining of these air sinuses, they will get pain in the face, front of the face. That is one of the features of sinusitis. if you look from the side, sagittal view, so maxillary sinus is somewhere around here, maxillary sinus, the ethmoid sinus is here, sphenoid sinus is here, ethmoid sinus is here, which means like nasal cavity, the very thin partition between the nose, nasal cavity, and the air sinuses. So if there is any significant infection in the air sinus, it can go into the brain as well. So abscess in the air sinuses can go into the brain and give a cerebral abscess. Paranasal sinuses, that these are the functions of the paranasal sinuses, to buffer against the forced insulation, increase the resonance of the voice, and humidifying and heating of inhaled air. All right, guys, so it's nearly finished. Just try to sit tight, And pharynx, we said nasopharynx, also oropharynx and laryngopharynx. It extends from the base of the skull to the cervical vertebra 6. It is everything we know about. We just move on. Larynx, hey, larynx, we didn't talk much about larynx yet. Larynx extends from the cervical vertebra 4 to 6. So larynx is not a very long structure. It is just our throat. It is just at the base of, at the upper part of the neck. It is beginning is highway bowl and it's continue as the trachea. These are the function of the larynx for vocalization. It's a passage for the air. It's direct and air and food, which goes into esophagus, which go into the trachea. So that is the function of the larynx. Don't forget the little epiglottis, which will close the larynx. Larynx goes up, epiglottis come down, close the airway so that the food we swallow can go into the esophagus. A few little cartilages, which good to know names: arytenoid, corniculae, cuneiform, and epiglottis. So epiglottis, we talk about that already. And this, it is not really important, but I think, if you remember this name, I want you to relate it to the larynx. You don't need to remember all these names, arytenoid, corniculae, cuneiform. You don't need to remember these by heart. But if you remember that, I want you to think, hey, it could be a cartilage from the larynx. So this is the hyoid bone, which is up here, which we can see if we lift up our head and neck. And this is the thyroid cartilage. Where is thyroid cartilage? That is what we call Adam's apple, which is quite prominent in boys because of the testosterone and growth hormones. So thyroid cartilage, hyoid cartilage, thyroid cartilage, and this is the cricoid thyroid cartilage. So these larynx, trachea, they are nothing more than a incomplete rings of cartilages. So they are C-shaped cartilages. They are not a complete ring cartilage. They are just a C-shaped cartilage. So the back of the cartilage ring is not complete. And this area is filled with the mast cell. So you have seen this already, the epiglottis and larynx and trachea rings. Look at that trachea rings. Trachea is the multiple C-shaped cartilage piled up together, and they are connected to each other by the elastic membrane and muscular membrane. I'm going to skip this. The epiglottis, trachea is C-shaped hyaline cartilage ring, which is like 16 to 20 hyaline cartilages. And they are joined by the fibrous tissue, elastic tissue. So C-shaped cartilage rings, one C-shaped cartilage ring, another C-shaped cartilage ring, connect together, about 16 to 20 cartilage ring, connect with the elastic tissue and fibrous tissue. They are complete, and at the back, where it goes and attached to the, so this is the C-shaped cartilage. This is the cross-section of the trachea. This C-shaped cartilage is C-shaped. It is open at the back. So this open cartilage is filled with the mast cell layer. So it just sits in front of the esophagus. Yeah. So this is the esophagus. This is the front trachea. Trachea is made of cartilage rings. This cartilage ring is open at the back. This back is filled with the mast cell. This mast cell is called trachealis mast cell. Of course, this mast cell, what does it do? When we swallow food, the esophagus has to expand, and this mast cell will give room, expand into the trachea so that the food can go through along the esophagus. Yeah. So trachealis mast cell, the importance is like that. And at the same time, this trachealis mast cell will go along with the right bronchi, left bronchi, finally bronchioles. And once it gets to the bronchiole, there will be no more cartilage rings. And alveoli, like dominant bronchiole, no more cartilage ring. And these are made of only the continuation of the trachealis mast cell. Therefore, these little mast cells can expand or collapse. Okay, so that is, we talked about this already, so I'm not going to repeat that now. Mediastinum, so we know that in the mediastinum, we have heart and great vessel, and the trachea, of course, esophagus, of course, and thymus. These are the contents of the mediastinum. Look at the heart, right lungs, left lung, cadaver, the diaphragm, dome shape, diaphragm, dome shape. So the right lung has 3 lobes, upper lobe, middle lobe, and lower lobe. Left lung has got big cardiac notch. Cardiac notch is written here. And this is looking at the mediastinum. Oh, right. So that's the mediastinum. This is the posterior because this is thoracic vertebra. This is the sternum, chondral cartilage. These are the ribs on the side. And this is the heart in the mediastinum with its great vessel, the right lungs and the left lungs. Right, guys, I know it is quite a lot, but I think the first hour we were just